I think the underlying feeling for COVID-19 has been one which I share with you right here. Here has been, an example of a real information epidemic. And in fact, at the WHO, when this all started, early February, March, we were hearing, the Director General saying, we're not just fighting an epidemic, we're also fighting an infodemic. And if you look at the graphic there, it's a simple line, right? There's a horizontal line with what you can sort of hypothetically think of it as being high fidelity evidence, and then below being low fidelity evidence above it and higher fidelity evidence below. And if you look fundamentally at curves, you can imagine almost a situation where data-driven evidence in a crisis may actually take some time for us to accumulate that information. You might think of it through randomized trials that may get started early in that phase and ultimately then grow. And we'll learn a lot about the different trials and treatments that have been used. But at that first wave is going to be a lot of low fidelity evidence. There's going to be a lot of misinformation, if you can imagine in that situation. Now, there's going to be opinions, and there's going to be lots of opinions, and there's going to be a little bit of data in that first phase, maybe case series, maybe some prospective data, maybe some archived retrospective data, and maybe even some early rapid results of trials or preliminary findings. But we're not going to get to the truth probably until we have a bit more time for these larger trials to collect data. So what do we do? Next slide. When we asked our network at OrthoEvidence, what are they looking for in terms of information? How are they getting information, and where is it coming from? If you look here, trustworthy individuals, especially in that early phase, that group of experts are individuals at least have perceived that are using some degree of data to defend, right? Beyond just presenting ideas. Next slide. And when we ask individuals, well, what is someone who's trustworthy? Well, that's someone who's going to be transparent, someone who has a resume that supports expertise, someone who's going to use high quality data in support of opinions, and they're going to have a strength of reputation of their affiliations. And ultimately, other individuals who are trustworthy would be providing testimonials for these types of individuals. Next slide. We did a quick review, and this was earlier on. This has probably been late March, early April. And over a period of about 9 weeks, there were 1,741 articles published in 59 countries across 447 journals. And remember, all of this happened in that 9-week period. Papers were getting published anywhere from 1 to 10 days after submission, and often, rarely taking longer than a few months. So we started seeing this real big uptake, and that creates a little degree of concern because there's so much information. But look at the proportion of information. There was a lot of review and commentary and not a lot of data-driven publications that were coming out. Keep a note also that the highest impact journals were in fact having a greater proportion of commentary and expert opinion and reviews over data, and there's lots of reasons why that could be happening. But at the end of the day, we are fully involved in a information demic, and we have to figure out how we're going to get new information. Next slide. And here brings me to introducing our keynote for this evening, which is Professor Gordon Guide, who is a distinguished professor in the Department of Health Research Methods, Evidence and Impact, and in my mind, the founder, but certainly he's humble enough to say a founder of evidence-based medicine at McMaster University. Among many other accolades, being a top-cited researcher in the world, being a recipient of the Order of Canada, and many, many other goals. I think of our journey, at least starting 15 years ago, when I had the privilege of joining what was a relatively smaller group called the Clarity Group, and how time has changed, and this group has really grown in the last decade or so. If I go to the next slide, please. So it is with great pleasure that I get the opportunity and privilege to introduce to you a friend, a colleague, and a mentor, Professor Gordon Guide. Welcome, Gordon.
Thanks very much, Moet. So I gather that I will be able to share my slides, right?
Correct.
Okay, so let's see, here we go. Share screen, share, and nice picture, but the slides will come in 1 second. I hope. Here they come. Okay, so as Moet has said, the content topic is COVID. The methods topic is developing guidelines. So I'm going to start off with standards for trustworthy guidelines. The Linan will take over with grade for trustworthy guidelines. I'm going to tell you about some old COVID guidelines that we published, old now being more than a month ago, latest in COVID results, and future of COVID guidelines. So I'm going to go through briefly, excuse me, each of these trustworthy standards, an appropriate panel, systematic review of the best evidence, rating of the quality of evidence and strength of recommendations, where Linan is going to introduce grade, explicit values and preferences, and transparent presentation of review results. So first, what makes an appropriate panel? So panel needs content experts, often researchers who have published in the field. And when Moet said, what are ortho evidence users looking for? They're looking for these experts. And if you go back 20 years ago, a typical guideline panel used a method that has been referred to as GOBSAT. The GOBSAT method of producing guidelines is good old boys sitting around a table. And it was these content experts that the orthopedic surgeons perhaps are still looking for, were the ones creating the guidelines. And that, it turns out, we think was quite problematic. And we'll talk about some of the reasons. So we now think we need such individuals in a guideline panel, but we also need methodologists, people like Moet and me, perhaps, and Linan, who you'll meet, who are experts in interpreting evidence. We need frontline clinicians, because both content area experts who spend most of their time in producing research, and in days before COVID, traveling around the world on attractive junkets to present their work, and may not have the insights that frontline clinicians have. And nowadays, we believe that it's useful and is very highly desirable to have patients on the panel. Who should not be on the panel? And if you go back to the GOBSAT model, one of the real problems was that the experts were often highly conflicted. They were often people, and unfortunately still happens, but they were often people who had taken money from the drug companies whose drugs they were making recommendations about. Or in the orthopedic area, companies who produce the products and the devices that in fact are being recommended. So that is now perceived by many as highly problematic. Intellectual conflict of interest is very, it may be more powerful at times than financial. If you have published results, you get very attached to your own published results and think they are superior to anybody else's. Professional would be, gastroenterologists tend to recommend colonoscopies, for instance. Possible approaches to dealing with the conflict of interest. In the GOBSAT model, it was ignored. Simple declaration of conflict. Many think that that is ineffective. Forbid experts with conflict from participating, get their input in other ways, or manage conflict of interest, either balance people who have different conflicts, or selectively forbid people with conflicts get to participate on a panel, but not for recommendations in which they are conflicted. So we get an appropriate panel together. They either find or commission systematic reviews of the best evidence. What do we mean by systematic reviews? Explicit eligibility criteria, and Linan will go over some of that. The PICO, patient intervention comparator outcome approach, methodologic eligibility criteria, often the most common methodologic criteria is restricting to randomized trials. A comprehensive search that gets at all the high quality or highest quality evidence, assessment of risk of bias of the primary studies, and doing various things in this process in duplicate, the judgment of the eligibility of studies, the judgment of risk of bias, and the data abstraction. So the next two steps have to do with rating of the quality of evidence and rating of the strength of recommendations. An approach called GRADE has been developed and has basically won the acceptance really of the international guidelines community. And Linan is now going to talk about the GRADE approach to rating the quality of the evidence and rating the strength of the recommendations.
So thanks, Gordon. So GRADE is a transparent and structured system for rating the quality of evidence and grading the strength of recommendation, which has been adopted by over 110 organizations, including the WHO, the Cochrane, and the UpToDate. So when we use GRADE to rate the quality of evidence, we first begin by defining the PICO question. For example, the PICO question could be whether the remdesivir versus the standard care could reduce the risk of mortality or the duration of hospitalization or the duration of symptoms in patients with severe COVID-19 based on randomized controlled trials. Until now, we have two randomized controlled trials which address these PICO questions. So in GRADE system, we rate the quality of the two randomized controlled trials together as a body of evidence instead of rate the quality at individual study level. So the randomized controlled trials in GRADE system start as high quality evidence, while the observational studies start as low quality, but both of them can be rated down. And there are 5 reasons for us to consider to probably rate down the quality of the evidence. The first is risk of bias. For example, the unblindness might lead to the bias in assessment of the duration of symptoms in the trial. And by inconsistency, that means the different trials or studies yield different results. So in that case, we may have concern of inconsistency. And then indirectness means the individual studies or trials did not directly address the PICO question we are interested in. For example, for P, we are interested in severe COVID-19, but the trials include patients with non-critically ill patients. And the imprecision happens when we have, for example, few patients and the confidence interval is very wide. And we might suspect the publication bias when the available evidence comes from a number of small studies, and these studies are funded by industry. And there are also 3 possible reasons that for leading to rating up the quality of evidence based on observational studies, but these situations are very rare. One is when there is a large effect, or there is a dose response gradient, or all plausible confoundings can increase our confidence in the effect estimates. So in terms of the strength of recommendation, there are 2 levels in GRADE system, a strong or a weak recommendation. When the benefits clearly outweigh the harms, or the harms clearly outweigh the benefits, we will end up with a strong recommendation. But there are also some other factors that may lead us to end up with a weak recommendation. So the first is when the balance between the desirable and the undesirable outcome is very close, we might end up with a weak recommendation. Or the lower the quality of evidence, the less likely a strong recommendation would be made. And Gordon will talk about this later, that the patient's values and preference is crucial in making recommendations. So when we are uncertain of the patient's values and preference, or the patient's values and preference vary, we might end up with a weak recommendation. And if a guideline considers the resource use or the cost, the higher the resource use or the higher the cost, the less likely a strong recommendation would be made. So a strong recommendation means or almost all that the patient would have the same choice, while a weak recommendation means the choice among patients varies appreciably. So the impact of a strong or a weak recommendation in our clinical practice is that with a strong recommendation, our physicians could just inform the patients, and next slide, Gordon, and may not need to bother with using the decision aid and have a very long conversation with the patient. However, with a weak recommendation, the physicians should ensure that the choice reflects the patient's values and preference by using the decision aid and have a very detailed discussion with the patient about the benefits and harms of the treatment. And in terms of the quality of care, a strong recommendation could be considered as a quality of care criterion, while a weak recommendation is usually not considered as such criterion.
Thanks very much, Linan. That was great. We'll now move to the last two trustworthy guideline standards: explicit values and preferences, and a transparent presentation of the review results. I'm going to hope that the presentation of what we know at the moment about remdesivir will illustrate the importance of values and preferences, and I hope you'll like, or you'll think that what I present to you will be a transparent presentation of the review results. Before getting to the remdesivir, I'm going to talk about a guideline that we produced, and you can see it was published early by the CMHA on April 29th. So this is how journals have been operating in the time of COVID. They have, as soon as the paper is accepted and with minimal processing, it goes up online and appears in a published volume of the journal subsequently. So we finished this guideline perhaps a week before, in around April the 20th or so, and appeared online on April 29th. This guideline was informed by 3 systematic reviews: one, safety and efficacy of convalescent plasma; a second, at the bottom left, of antiviral treatments; and a third, corticosteroids. And you can see that the systematic reviews actually appeared more than a month after the guideline. So again, this was a compromise. In the past, the systematic reviews would have to be available when the guideline was published. In this case, the journals, by the time the guideline was published, the journals were confident that these systematic reviews were high quality, that the results summarized in the system, that the results from the systematic reviews, which appeared in the guidelines, the key results, were credible. And so again, all of this expedites the publication process. So what did we look at in this particular guideline? We looked at steroids, both for serious COVID and for critically ill patients with ARDS, convalescent plasma, and antiviral drugs. The antiviral drugs we looked at are listed there. The values and preferences, we made them explicit, which guidelines should do. We noted that all drugs have adverse effects, and our value and preference was that we thought that the majority of informed patients would decline a drug if there was only very low quality evidence of benefit. You could argue whether that in fact does reflect patient values and preferences, but that's what we thought. The only positive recommendation was with steroids and ARDS. Why? Because for everything else, there was only very low quality evidence. And so with very low quality evidence and our values and preferences, we made suggestions. They were weak recommendations, but weak recommendations against using it. Why weak? Because there are some patients, we thought, who would say, even if you have no idea whether it works, if you tell me it might, and with very low quality evidence it still might, then we would take the treatment. So that's why it's a weak recommendation, because we thought values and preferences differ. We were, in retrospect, we were happy with our ARDS suggestion in favor of steroids, because you'll see steroids benefit patients with ARDS. For most of the drugs you see there, things have not changed since April 29th when we published this. There is still only very low quality evidence, and probably should not be, for most patients would probably not choose to use this. On the other hand, the one where evidence has changed is hydroxychloroquine. And although the big study has not yet been published, all it was a press release, hydroxychloroquine is not of benefit. And our suggestion against its use has proved appropriate. So at the top, there is what I've just told you, one large negative trial not published, but nobody should be using hydroxychloroquine. We have finally a treatment that lowers mortality in patients with COVID, and that's dexamethasone, a corticosteroid. In the trial that now has a pre-publication abbreviated summary, but enough to give us have a good idea of what the results show, 28-day mortality in over 2,000 patients treated with dexamethasone for over 4,000 usual care, mechanically ventilated, a 35% relative risk reduction, about a 10% absolute. Oxygen, but no mechanical ventilation, a 20% relative risk reduction, 3.5% absolute. No respiratory support at randomization when actually went in the wrong direction, but non-significant. So once you get sick enough to need oxygen, steroids are going to lower mortality, and the biggest effect is likely to be in the sickest patients. Now, here is the evidence summary for remdesivir. And what this tells you is the outcomes on the left side, study measurements and relative results. So if you look at mortality, the best estimate is that remdesivir lowers mortality by about 34%, but the confidence interval is from a 60% relative risk reduction to a 14% relative risk increase. If you put this into an absolute effect, it would be 85 fewer per thousand. However, it includes 30 more because the confidence interval crosses no effect. We thought, we thought that was low quality evidence, and we also made a plain text summary. The effect of remdesivir on mortality remains uncertain. Mechanical ventilation, very little difference between the two. Summary, remdesivir may have little or no effect on mechanical ventilation. Serious adverse events, a suggestion of 19 more per thousand, but again, wide confidence interval, low certainty evidence from remdesivir may increase serious events. Hospitalization, little or no effect on hospitalization so far. Why did remdesivir get some press? Because it apparently lowers the time it takes to get better. The time that patients feel better, they don't need oxygen anymore. A 3-day lowering of risk, but, sorry, a 3-day lowering of duration. But the confidence interval includes a reduction in the duration of symptoms of less than a day. So we rated that down for imprecision as one reason to rate down, because we thought that if it's less than a day, most people would consider that an unimportant effect. And so we say remdesivir may reduce time to symptom resolution. And mechanical ventilation duration, suggestion of a benefit, but again, low quality evidence. So that's the story with remdesivir. Different recommendations are appearing. And I thought maybe we can come back to this because part of the discussion may be if you're on a guideline panel and were presented with this evidence summary, what would you suggest? Because, and it highlights different values and preferences, because very different recommendations are appearing given these data. And finally, this illustrates a network plot from a living network meta-analysis, which we have ongoing on a daily basis. We are keeping track of all the randomized trials of any of the drugs that are suggested for COVID. We are putting them into this network meta-analysis, and the advantage of a network meta-analysis over a conventional meta-analysis is it allows both the direct and indirect evidence to play a part. So if you're interested in ribavirin and lopinavir, ritonavir over just rilpanavir and lopinavir, that's the additional of ribavirin. You could not only have the direct comparison, but the indirect comparison with ribavirin could also inform the recommendation. And we are hoping to very quickly produce guidelines using the evidence from the network meta-analysis. And those guidelines, we now have an arrangement. The project is being supported by the British Medical Journal, which is going to publish rapid recommendations, which we've been doing them for a while. But what we're doing is also going to support WHO recommendations as well. So that is the summary. What do you think, Moet? Should we start by going back here and asking the people who are attending what they might recommend, any questions about this table that presents the results of remdesivir, and what they might see if they were making a recommendation for or against remdesivir, strong or weak, what would it be?